Good evening, everyone. It's a great honor for me to be able to be invited to speak to the Viva Learning Group, and we will have a lot of fun tonight. As most of you can relate, particularly in these days, and for the younger persons and students, the days are long and the years are short. So enjoy everything you can right now, and you will find it will give you great gifts in the future. Today, we're going to learn about the crown jewel of dentistry and why EMAX lithium disilicate restorations pass the test of time. This is a photo of my son taking a photograph with two bears in Montana, and they're about to collide with a rainbow, and 2 seconds later, he will be soaked. We've all come through COVID, and this was Boston, I guess last March. And one would never believe in the middle of the day, one would see such empty streets. And City Hall was always lit up red, and you could see that there were no planes, no action, no anything, and really quite amazing times. So today we're going to learn about the interdisciplinary solution to aesthetic periopros rehabilitations, and we're going to understand ceramic science and its impact on interdisciplinary aesthetic prosthodontic rehabilitation. Quality is never an accident. It's always a result of high intention, sincere effort, intelligent direction, and skillful execution. It represents the wise choice of many alternatives. I dedicate every lecture to the wise choice because, in fact, there really is no perfect or real answer to solve the very complex problems sometimes patients present with. The people we surround ourselves with either raise or lower our standards. They either help us to become the best version of ourselves or the worst version of ourselves. And we become like our friends. And no person becomes great by themselves. We all need people in our lives who raise our standards, remind us of our essential purpose, and challenge us to be the best versions of ourselves. I think this is very important. We're all in this together. As you can see, I've been a member and served on the American board since 2002 of prosthodontics. So I've learned from some very great minds and have great friends and mentors. I've also been blessed to have great dental technologists in my office. These people have more education, spent more time in school and training than my residents do at Tufts. They're all 6-year masters, and I've learned more from them than they could ever have taught me. But the bottom line is, even in the world of CAD/CAM, dental technology is the heart and soul of dentistry, and we need them more than ever to really make our work real. One problem is that dental technology programs have dropped so precipitously from 1983 to 2021. And many of them now are just learning CAD/CAM techniques. They're not really learning to wax. They're not really learning to color. They're not learning depth of color. And this becomes a very important part to what we can expect our patients to be able to make our patients happy with all of the complexities of the aesthetic care. Dental technologists understand the truth is the exact duplication of colors, textures, lines, and shapes down to each microscopic detail. That makes the whole. Dental technology makes us whole. My specialty is expanding. We have explosion of modern technology, but not all of it is ready for prime time. And remember, all the modern technology has to be cared for, and we have to learn, and there's new programs, and there's new computer powers, getting better all the time. But in 5 or 6 years, we're going to have to replace them. Increased complexity of care for sure, and patients really want to look good at any age. Not everything I'm going to say tonight is going to really reflect on your thoughts and what you think is true. And for scientists, altering one's doctrines when the facts change is not a sign of weakness. it too represents the wise choice. Life can only be understood backwards, but it must be lived forward. My residents, and when you were all dental students, you were being taught theory, but backwards theories. You were being taught things that work, clinical experience. We can move ahead with new ideas as we do, but one always has to reflect back on the education and the principles that you were inherently taught. My mentor, Jerry Kramer, when I was a graduate student, emphasized that everything we do should be simple, accurate, predictable, and consistent. And I've spent my whole career doing that. Well, prosthodontics has created almost every topic at the highest level, whether dentures, occlusion, minimally invasive dentistry, perioprost and ortho, adhesive dentistry, dental ceramics, implant dentistry, evidence-based dentistry, digital and CAD/CAM, all came from the prosthodontic specialty. And all the papers and all the textbooks are written from my colleagues. Steve McCurry found this beautiful woman, and on the left you can see the nobility that she has, the pride that she has in herself. And he found her 20 years later, but by that point she was edentulous. And it's our job always to try our best to restore our patients to a world where they are comfortable and have dignity. That's our essential purpose. So my wife at the American board presented a patient who was very unhappy, was not functioning very well, had very poor aesthetics, and with implant retained complete dentures, she was able to return his dignity. So this is the patient who has a diastema and is not happy with her aesthetics. And resume share. And we used Christian Coachman, a dear friend of mine, and we use his slides, the smile design to communicate to patients and to communicate with the technicians and perhaps other specialists. We have the ability today, as we've had for years, to make beautiful veneers in feldspathic with great translucency and lots of layering. And we can make beautiful veneers, as Thomas Singh has done here. The issue is many patients really don't want translucent today. They would like white teeth as much as they can get. And that in itself presents a problem, because they may like it one day and come back 3 months later and not like it. And cutting these off is not easy. Herb Schillingberg, but others. I grew up in a world of the gold onlay. My world was always the gold onlay. That was the standard of care. But Herb Schillingberg's photograph from his textbook shows very well that all of this is enamel, and all of the hollow grind, everything can be, and the fins opening up, all of this is a perfect substructure for luting and acid etch Emax restoration. So I had practiced with Bob Stein, and you could see the gold onlays, and they were beautiful, and they are beautiful. Not all of them last, but that has always been the standard of care. And I spent my career doing that. There are many great people who can hand layer composite resins, very difficult restorations to do, so that most of the big names in this area are now using blocks to CAD/CAM the restorations. One issue should be noted that the CAD/CAM pressed resin blocks are much more expensive than an Emax block. An Emax will never break down, never have micro leakage, and never be inherently a problem. So one should consider that. So the simplest restoration, it's a class 2 decay. I opened it up and acid etched all my enamel, Gluma, Dentin Bond, and acid etched ceramic Emax, and bonded them together. One can do this in CAD/CAM today, and one can do it very effectively. Great dentistry is about materials applied more than the technology used in the process, and I think we're forgetting that. It's certainly true that technology makes the process go faster and easier, and we're less dependent on these extraordinary ceramic artists. But the aesthetic and long-term survival of a material, that is what defines success. So for 38 years, I have had a prospective in vivo survival study of Emax, Empress, Inceram, Dicor, and someday zirconia restorations. And as of today, I have done 8,035 units, but most important, the most successful material we'd ever studied was Empress, 2144. I've had 127 true failures and a gross failure rate of 5.92. But Emax is off the chart. It's essentially bulletproof. I've done 4,058 units, 28 failures for a 0.69% failure. You can see at the bottom, I've replaced a lot of units to change treatment plans. That's part of dentistry. And one could recognize that that's an important part of a dental practice. Over COVID, my wife and I published these 2 papers, but we have published 3 papers so far. There are 3 more coming out soon. And we break down all of those numbers into confounding variables as we'll study that. So the first question is, in Europe, the partial coverage restoration is a passion. It's if you don't do partial coverage, you're not a good dentist. And they're very passionate about it. So we have to first ask ourselves, well, how does that relate to Emax? First of all, you can see I do a lot of partial coverage. Emax allows us tremendous versatility. And since it's, as you can see, it's generally bulletproof, it's a simple restoration. And my mentors used to tell me, if we could do 2 of these, 3 of these, 4 of these a week, it would help pay for your overhead. I believe that to be true. So at 10.9 years at 556 units, looking at partial coverage and different confounding variables, you see some interesting things. First of all, you can see that the inlays and onlays have very few failures. And the survival function is very high, overall 95.6%. That's extraordinary numbers. I've been studying this for a long time, 38 years, and we've never seen data like this. Now you look at the Kaplan-Meier, which is how you study statistics, and you can see there's no statistical significance between the inlay or onlay Emax restoration. So let's take a patient. She's worn her teeth down, she's unhappy with her aesthetics, she's unhappy with her occlusion, and she comes into protrusive and she's hitting all her posterior teeth. I wanted to do the simplest restoration, but there was decay and problems. And by simple, it means you just cut a cross in here and just add that, etch that, and build the case up. So I have to restore vertical dimension here. Now, as I said before, we all need people who are going to make us better people. My greatest mentor was Frank Salenza, Harold Litvak, Lloyd Miller, and Niles Gachet and the great Peter Dawson. These are all good friends of mine. And when I was a young dentist, Chicago at the Equilibration Society, but occlusion. I was right in the middle of the wars. It was great education. So the first thing J. Hart Long taught me was to use a leaf gauge, open the vertical dimension, and see how much space you need on the articulator to build this case. I use an electronic pantograph. I always use a face bow. And these are my preparations. And you can see I'm hollow grinding and bonding almost entirely into dentin. Cement the posterior teeth first. And then you see that I have an anterior open bite. Well, that won't do. I don't do a dual technique where I'm going to do a one restoration lingually and then a veneer on the labial as they do in Europe. My sense is to do a complete crown. And then the question is, how do they look? How do they function? You can clearly see my protrusive, the posterior teeth are separating, centric relation, protrusive, the posterior, and that's what you want, mutual protective occlusion. So anteriorly, they free the posterior teeth and take away all those lateral forces and tensile forces that could break a ceramic restoration or a tooth. The before and after Stanzani did was beautiful. So now let's look at the question that the Europeans seem to be obsessed with. Here we have 2,392 units, and you see that there is no difference between complete coverage or partial coverage restorations, not at all. And when you look at the survival, the Kaplan-Meier, there is no difference. So if you feel you need to do a crown, there's nothing wrong with it. Doing inlays and onlays, that's the easiest dentistry. Well, it can be some of the easiest dentistry going. Now you look at the question of thickness. Less than or greater than, there is no statistical significance between any of them. And as you get thin, you're almost entirely bonding into enamel, and that could be adjusted, and you would not expect fractures. So here's a patient with amelogenesis imperfecti. The teeth, the enamel is just falling off the teeth. I chose to do crowns, and this is the end result that Thomas Singh did. It's a beautiful case, and it separates the posterior teeth. And today's standard, your level of dentistry today, easily, it's hard to distinguish between a crown and a natural tooth. Another patient presents no anterior guidance, no, just about an anterior open bite, and protrusive, the posterior teeth are touching, the teeth are prepared, some implants were placed, and eventually, within a couple of weeks, you could do this in 1 week, but you really need to go through a treatment wax or a prototype to make sure that your line angles, your color, everything would line up properly, and the occlusion would line up to what the patient ideally wants. Once after that, it's just a press or CAD/CAM and color. Very simple. The aesthetics is wonderful. Now, I've had great friends. Diane Riekow and Van Thompson are both PhD engineers first and then became dentists. Diane became the dean of the dental school in London. They created a science group that has taught me so much, and I could never thank them enough, because everything I'm going to show you now is based on hard science that's been published. So the first statement is, we knew a lot about feldspathic zirconia restorations and the potential for them to break. When you look at Emax, you can see it's really off the charts. Modern day zirconia could be off the charts of the contraplat. And you're looking at certainty, fatigue strength, and clinical performance. The reason crowns break is because subcritical crack growths aided by water and stress. Initial strength is exciting. It's not that important. Stress distribution is important. That's why we use resinous cements, whether it be resin ionomer cement or straight resin cements. They will allow for stress distribution. Damage accumulation is important, and ultimately I study crown life. And I go back. We're going to be looking at 4,058 units with a failure rate of 0.69. Van and the group did my favorite study, and you can see you had 90% failures in zirconia feldspathic after only 100,000 cycles. Let's look at that. Off-axis load, calibrated in water, sliding contacts, 350 newtons, only short amount of cycles, chip. This happens in feldspathic as well. And now the lithium disilicate, 1,000 newtons and nothing. Once I saw that, Empress and most everything else from the single units was gone. So Petra Goose did a study where she created a wear facet, and then she cut it in half. And now we look at how much extension, not much there and not much here. And she showed how that could be polished out. And it will not lead to fracture. And even here, not great dendritic extensions. So we see here from Paulo Coelho's work that everything we do, every crown we make, the stiffer the core, the less is this motion, but everything opens up. Water, bacteria gets in there, particularly if the margins isn't perfect. And then the great John McLean showed that you get the crescent fracture, which we call the semilunar fracture. Materials break because they flex. Our group studied the semilunar fracture, and a force here is extended out to the sides. And all of these fracture generally because of forces internally out. And why, when we have a keg of wine, which some of my friends are drinking right now, we always put a steel girder around it to prevent blowing the barrel up with fermentation. When you look at my work, a force applied here, bending moments, and internally, that has tremendous effects, and you can see the semilunar fracture. This is exactly why and how Harold Heyman describes the fracture in enamel. The abfraction unit has the same, and I could have shown this as ceramic, it would look the same. Forces come out and from within can break the restoration. Just looking at this theory, fracture resistance is part of the modular's elasticity supporting structure. And my favorite candy cookie is a Malamar. You have a nice chocolate outside and a soft marshmallow inside. We apply an indenter, we push, and now we get the semilunar fracture. So it's the simplest concept, but fractures happen internally. When you look at Emax breaks all the rules. Everything is now changed. When you look at this compared to Empress, there is no pattern that could be described accurately why an Emax restoration breaks. And we've tried, and we've studied this in great deal, sending our work to Switzerland and, of course, to London. And it's not easy to figure out why these break. So at the 10.9 years of 1,960 units, first of all, the survival rate is 98.3. Perhaps what's more important is the crude estimate percent of failure is 0.003. Again, this is off the charts. We've never seen anything like this, and it's hard for me to imagine that we ever will. The estimate risk of failure is 0.14% per year. That you take to the bank. This material is bulletproof, but they can break, and even with hard cores. And on a 75-year-old young patient, it's very unusual, and we can't tell you why, when, or how these things happen. But we do know that certainly I do a lot more posterior teeth than anterior teeth, and we don't get many failures. And we look at bilayer, and again, you see that bilayer metal ceramics, zirconia, feldspathic, they have been a huge problem. Those restorations chip. But in Emax, they don't chip at all. Now, remember, the bilayer restorations are principally in the anterior region. Now, Van and our group did a study looking at the reduced thickness, and they found no statistical significance between the monolith or the bilayer material. So we know that physically this is true, and now we've seen it clinically. Looking at the statistics of 10.9 years, there is no difference between a bilayer and monolith. But remember, the bilayers are principally done, and we've even changed the way we bilayer. Kaplan-Meier, there's no statistical significance between the two. Now remember, this is a huge statement because metal ceramics chip and zirconia feldspathic chip. There's no question. The movie I showed you before is still happening. Now, gender with all the other materials has been an issue. Males break more than females, but with Emax at essentially 11 years, there's no difference between the two. Now, when we extend it out to 16.9 years and 2,393 units, the overall is very little. These restorations don't break, and gender or sex is just not an issue. When we look at age, you imagine a younger person with greater force? Nope, there's no difference between 33 or above in any capacity. So we know the position is important. Molars get a lot more wear, a lot more tensile forces. And my dear friend Lyndon Cooper comes out with a statement, well, you have a virgin tooth, then you get caries, you do a restoration, the tooth fractures, then you have to do a crown, and then of course it needs endo, and then you get root fracture and then implant and peri-implantitis. Well, we have now asked ourselves, how many of my teeth actually fail? And after 37 years in a paper that is almost ready for publication now, we've seen only 113 restorations requiring root canal after we've done a restoration for a percent of 0.015%. Now, remember, the literature is going to tell you 30 to 40%. And that, in my mind, is completely ridiculous. And the papers, and there's no long-term survival of the 30 or 40% of people that failure rate that's been reported. This will set a standard that'll be very unusual. So what does this mean to me? First of all, we practice at the belief level, and I recognize I spell belief wrong. We listen to people, and we believe, and the commercials out there are incredible. We believe everything, and as dentists, we sort of like to believe. But one has to be very careful because there are lots of passionate storytellers, and many of them make a lot of money doing it. And you have to really be careful what is real and what's true. So be aware of what you see and ask questions all the time. Talk to your friends, talk to your teachers, look in the literature, get a sense. Prosthodontic treatment goals, all of our treatment goals to eliminate disease, restore occlusion, aesthetics, and function. But our treatment should decrease long-term risk for that patient and treatment with dental materials that have a proven long-term survival. So this left central required a crown. Let's look at the color factors. This is a big issue. First of all, take in Photoshop, high contrast, look at chroma, and you can see lots of color. Then you put it into a black and white and look at value, and you can see all the chipping and cracking. So made a crown. It's most important to remember that you want to create a thicker neck, thicker external bulge so that lines come down on the line angle. That's a key point. But look at all the translucency that was created by Thomas Singh. Looking at it now in Photoshop, everything that we wanted in our color match, in chroma, and in value comes. So although Emax may not be perfect, we're not fighting opacity. We're not fighting anything to be able to deliver a restoration that has the potential to have the best color we've ever seen. Now we can do a crown and cantilever, even with gingival ceramics. I've never seen one of these break. And with a failed Maryland bridge, and you decide, well, I would like to do a 3-unit bridge, that's possible as well. I wouldn't expand it much further than that, but Emax in a short amount can be done beautifully and the aesthetics matching almost perfectly. Now you have patients that I treat all the time where the vertical dimension's lost. She's unhappy with her aesthetics. In protrusive, she's pushing the back teeth. She's created serious subtractions. So you know the patient's teeth are under stress. And in protrusion, they're hitting. We want to create anterior guidance. We want those posterior teeth to separate. So individual units, we did this, and protrusive, the posterior teeth are separating, as you can see. This is important. This is the goal that we would like, anterior guidance. Now another patient, loss of aesthetics. We have to reestablish occlusion. Perio is going to need to be done. Implants are going to be done. Initial preparation, pantograph, check vertical dimension, make the provisionals to that vertical dimension. A treatment wax or a CAD/CAM guide is made, and you have to test that. Look at it. How the patient stand up. Is the midline right? Is the cant right? Lots of things to think about. Does the patient like it? Sometimes patients will say they even like the color. Now, this is important. I use a cementation guide that I made a triad on my master cast. Most important, today, I take a burr and I just cut divots into the Emax complete monolith. And from there, we're going to micro layer color, and this is what we're going to get. Look at the level of translucency that we're able to get in Emax and the ease that we're able to do it. And also, Emax is the least expensive material from the point of view of a press or a block that we have on the market. Imagine if you had to do this in metal ceramics. And time, I could do this in 2 or 3 days. So the smile is everything, and the great Jackson Pollock, facts are illusions, and they, in fact, can be equivalents. Here's another patient, real rare, and these are the patients that are in my database. So centric relation, protrusion, the back teeth are pounding, and the wear is significant. So I prepared the teeth, the maxillary one day, the mandibular teeth the next day, and then I had a periodontist apically repositioned to get a longer tooth, which is going to make the teeth stronger. I take a pantograph, I use the leaf gauge, I use Delar wax to take a centric relation record, which was Peter Dawson's favorite, and I love it too. Then I use a cementation guide to organize my cementation procedure and taking all the stress off of me. And then this is the patient in centric relation, in protrusion, centric relation, protrusion, the back teeth separate. The before and after is really inspiring. And look at the wear and the final restorations. And of course, we use a night guard. It's really important to recognize that you can look right through these restorations. Sometimes there's a gap, and sometimes you have to do those crowns over. But in general, you see so much more with Emax than we've ever seen with any other ceramic. And the aesthetic is really important. So here's another patient. And one could say, maybe we should extract all these teeth and do an all on 4, all on 6. I don't think so. The protrusion, the posterior teeth are touching, and you can see the wear pattern, which is profound. So I prepare the teeth one day, maxillary, the mandibular teeth the next day, and then with the provision at the new vertical dimension, provisional, then I had a periodontist apically reposition to get a longer tooth, which can make everything stronger. Then I use the treatment wax at the new vertical dimension. And then this is the final restoration. This chip is because the patient wanted not to look so perfect. So chip here, chip there. He thought that was great. This is the patient in centric relation and protrusion, and the before and after is great. And that, we all drink the Kool-Aid. We think single units are so great. Well, this patient had a lot of wear, a lot of effraction, which you know that the teeth are under stress. And I drank the Kool-Aid. I prepared the upper teeth and the lower teeth, and I made individual lithium disilicate crowns. Only problem was 3 years later, the contact started to open. There was tooth mobility, and 3 years later, I had to cut the teeth off with a zirconia cutting burr, and carefully done. And then I did a milled prototype, and it's important to recognize that you have to look at your prototype or wax up, because the margins may not be what you thought you scanned, as it was in this case. So I routinely use a polyether impression, whatever impression material you use, which the literature says is important. Then this is what I use, Zircad Prime. The Culp did the work, and he did a beautiful 6-unit splinted restoration. Another patient, this is gingival root ceramics. Everything was wonderful. 4 years later, there was problems of mobility. So I took them off, re-prepared, and again, I did a Zircad splinted restoration, and they are doing beautifully. One could always ask this question, well, what about metal ceramics, how it compares to Emax? Well, the teeth are prepared, implants placed. On the upper, I splinted the teeth so that I could use metal ceramics. This is the metal ceramic splinted units. On the mandibular, I did Emax crowns. No one can tell me what's what, but we have a master technician, one of the greats. How many great technicians can do this today? It's a problem in my practice. It's a problem for everybody. And of course, in CAD-CAM, particularly in zirconia, that becomes a big problem because it's inherently an opaque material, although getting better. Prosthodont, my specialty, is the most capable specialty to manage complex dental problems in concert with other specialties. But there are problems. You can see contacts open, and when the contacts open, you might get caries. So this is very well documented. And the percent, 27% after, this plagues me every day. Then my friend Rich Smith showed that, in fact, depending on the size and the contour, one might even start to expect caries. And of course, these teeth are going to be lost. It's a huge problem. Not everything should be an implant. And maybe we have to start asking ourselves, do we have to go back to more conservative dentistry? But certainly on an anterior teeth, that would be right. We did a gold site developing coping, and then we have to choose an abutment. We could do gold, titanium. Zirconia has potential problems. The tie-based restoration has the best fit and can be done best of all. Michael Kloss and Tom Taylor showed us if you use zirconia and it goes into the implant with micro motion, you are going to abrade the titanium, and that's going to go into the zirconia. And the preset is not going to be as strong, and that implant may fail, as well as the zirconia might break. And they reported tattooing. And this is all of this is titanium from the implant. So I chose to do a tie base for my patient and friend, and I think the final result here is on just 2 teeth is really outstanding. So this would be my choice of how I would want to do it. Now, my wife has shown me very clearly, and she's a prosthodontist, has shown me very clearly that implants can be placed, but there is a defect, and there is a horizontal defect, and individual abutments is just never going to restore aesthetics. And the vertical issue is huge. And again, the horizontal issue is huge. So the complications are very big in the implants we do. And that's why for years ago, and I wrote the first papers on it, although it first came to me from my friends Jörg Struben and Uli Grunder in Switzerland, about ceramic gingival aesthetics and gingival form. And you can see these implants were all subgingival. After 31 years, they're super gingival. So gingival ceramics now takes away a lot of factors that we will not have to worry about. On a 57-year-old, placing 2 implants, doing a subframe and a superstructure in gingival ceramics is very predictable and very good. But on an 81-year-old patient, we could do a fixed partial denture, a fixed bridge. We've done that for years. And even with gingival ceramics, they can be done beautifully. One has to ask yourself, what are we doing to our patients? This patient represents everything that is what I would have done years ago in the ceramics with limited space and symmetry. Remove the teeth, huge defects, now my residents in pros don't learn how to do this. This is done by an oral surgeon or a periodontist. Big grafts are done, implants are placed, and I don't care where the implants are placed. Do a treatment block, the patient really looks like she could run in a horse race. So we did a subframe and then a superstructure in metal ceramics, can be done in zirconia as well, and the aesthetic result can be just outstanding. This represents what I did once upon a time in my life and what I would do today. And the before and after is just outstanding. And this is the nature of my specialty. This is what prosthodontists are being taught today. This is what is being presented at the American board to us. Now, Mayo Clinic showed us that the implants are going to work with our fixed prosthesis, particularly resinous, but the resin restorations may not work at all, and the failures are large. So it is your worst day to realize that teeth pop off of resinous materials all the time, and we don't have a diatoric. We have no real way of keeping them in. So this patient was presented with an opportunity to have a fixed restoration. I pantographed. I set the denture teeth myself to the standards that I was taught, and then I did a gold subframe and then a superstructure that is going to be luted or tapped into the gold frame. Zirconia is popular, but there are big problems. 90% of them in a 5-year retrospective had problems. including major and 17.6 fractured. Most of the time, it's directly related to the laboratory cementing the abutments into the zirconia. And you can see with micro leakage, they come out. With micro motion, you get major fractures. So this is not how it should be done. So I was taught to make our impression, use a confirmation jig to make sure that our restoration is down, of course, with radiographs. And then I set the teeth myself, set the vertical dimension. And then in the end, the CAD/CAM was done. And I made a prototype that the patient wore for a month and a half. And she ground the occlusion down. Obviously, it was going to be mutually protected. But the bottom line is, then we scanned, or the laboratory scanned the occlusion and made the restorations to it. So this is what the computer showed us. We made a thick titanium bar, which was CAD/CAM'd. Then that goes into the inserts. You can put some luting material, but overall, it's going to be screwed down. That ultimately, we're going to come up with something like this. So this is what Josh Polanski did, the great technician. And you can see the zirconzon technique where you have a titanium bar. The zirconia cannot flex against this bar. I have not seen any fracture, nor have any of my friends with this technique. And remember too, this is what's going in the mouth, the gold abutment, or the titanium abutment. Now with the milled zircad in protrusive separation, centric relation, protrusion, lateral protrusion. With angled abutments here, we're able to do this. And when you take them out, if you had to take it out, just the look we did initially, and the tissue is pristine and just wonderful. So to end it, it's not our abilities that show what we truly are. In the end, it's our choices. And with that, I will return this open and be happy to engage in the questions that may come. Thank you. I have read that Emax requires 1 millimeter reduction for bonding, but have seen many recommend 1.5 to avoid fractures. What are your thoughts? Well, as I showed you, they are not coming from anything of learned knowledge. We have been doing Emax for a long time. I showed you that you can get way under 1 millimeter, and I have no fears about doing that. So no, I do not believe that that's true. I know that people have said that. It's just factually not true. And they use that as a reason not to do Emax on molars. To me, the reason you do Emax on molars as opposed to zirconia or other materials is once you bond them in and lute them in with acid etch, Gluma dentin bond and acid etch, silane Emax, those restorations are not coming out. Those will not spontaneously come out as will all the other materials. Bilayer means a feldspathic material, or in this case, a fluorapatite material being layered onto a press or milled lithium disilicate. Jess, your question is a hygienist. My concern with splinted teeth is patient home care compliance. I've seen many times more bone loss and even some patients lose teeth. Imperial Pros, for the last 60 years, the splinted restoration have been the most outstanding. Look, I still drink the Kool-Aid. I still do most of my work in single units. But the problem is that with time, contacts open and teeth have mobility, as I showed you. At that point, you can't go back to single units. You have to open up the embrasures and allow for superfloss, for good cleaning. I teach all of my patients, as does my hygiene staff, to use material like Listerine, a mouthwash first. Use an electric toothbrush that the great Sokransky published a lot on, and use that for 3 minutes, and you should get a great result. I feel very good about Emax because toothbrushing has never shown itself to be a problem, losing anything. And since, as I showed you, I'm doing micro layering, I've never seen color come out of this, as I certainly have seen in metal ceramics, color come out. Octavio says the horse race. That's hilarious. Thank you. What do you think about lithium disilicate press? Well, the vast majority of restorations I do are lithium disilicate press. Why? I have my own in-house lab. I can put 3, sometimes 4 restorations in a press. Lithium disilicate is the least expensive material we've ever used. If I get 3 restorations and the material pressing block is $70, cost me $25 to get 3 restorations. Come on, we're in business. It is the best material we've ever had from the point of view of cost effectiveness. And the labs should be pushing some of that to us. It's not a premium product, it's the standard of care. What is the longest span? Rafaela asks, what is the longest span you prefer to use? 3 units, I don't do more. I know people have, but 3 units, that's the end of the story. Arjan asks, would it be possible to have a PowerPoint? I don't think so, but I gave Viva Learning a PDF file, and that you're certainly welcome to. Did your findings differentiate between cement types and the effect of emails? Effects of strength. My work with Dicor, I was the first one that got Corning and Dave Grossman to create an etch for Dicor. It was a 10% ammonium bifluoride, an etch, and we etched dye. And in that work, then we proved that it was at least 2 to 1 better than using zinc phosphate, a classic zinc phosphate, or a glass ionomer, a classic acid-base reaction. I do everything with resinous materials, and I don't care whether I use pure resin, but I don't care if you use resin ionomer, it doesn't matter. But I want to acid etch the tooth, gluma, dent and bond to limit sensitivity and the potential caries later on. I want to acid etch and silane the Emax, and then cement them together. And that's important. How long do you leave patients in temporaries prior to completing the full reconstruction? Well, after perio, it can take 9 months to a year. Sometimes if the patient's traveling, maybe even more. And at the new video, the classic statement at the American Board that Carl Driscoll and others have advocated is to put the patient and complex patient, to have them wear a guide to open up the vertical dimension, see if the patients are comfortable. In my world, with periodontal disease and decay, I use my provisionals to open a vertical dimension, and you can open vertical dimension very comfortably, 3-4 millimeters for prosthodontic convenience. I've never seen really a problem with that. And then patients wearing that, and I'll note if there's any bit of uncomfortable behavior from the patient, but I haven't seen that. Dan asks, I'm of the opinion we better serve with Emax rather than zinc. Zinc, I assume you meant, zirconia. I also believe preparation is the key to performance. Dan, you're right. Performance, the longer your axial walls, more parallelism, resistance and retention form has always been a key factor. That's why often I have periodontist apically reposition. Emax rather than zirconia, I agree with you completely on all teeth for single units. But when you come to multiple units, I don't know. And, if I have an issue on a second molar or a third molar, and I have a short prep, and I don't want to have a patient go through a major perio procedure, particularly from issues like the external oblique ridge, et cetera, I'll very much make an onlay, a classic onlay, and I'll make it in gold. And I'll cement that same procedure, sandblast the gold, acid etch, gluma, dent and bonding, and I'm very comfortable. But zirconia is getting better and better. The problem for me doing research is there's so many different zirconias, and one zirconia is not the only answer. One zirconia, the confounding variables are complex. So Emax, I'm just using that, all the other materials. I just had one material. But in zirconia, there's so many different zirconias, and that's a confounding variable. So Colleen asked, was that zirconia over titanium bar for the implant prosthesis? Absolutely. That's the Zirconzon technique that came from Enrico Steiger. I would not do it any other way. Create a titanium bar, zirconia over that, glued gently, but then ultimately luted the whole thing into the implant prosthesis. Never seen a problem. I have not known anyone who's seen a fracture in that way. But going the other way, particularly gluing into the zirconia, that's a big problem. And I wouldn't do it that way. DRGWT, do you always bond or do you conventionally cement? Well, I haven't used a conventional cement in 25 years. A conventional cement is a classic zinc phosphate or glass ionomer, and those are acid-base reactions. All materials today, whether resin ionomer or pure resin, and first of all, most of them are at least 90% resin, glass ionomer or resin ionomer. Just a little tincture of glass ionomer in there. But the bottom line, these are all resinous material, and they are free radical reactions. Those are free radical reactions. That's a polymer reaction, not a conventional. And that's a great question because people ask that. No one uses conventional zinc phosphate and glass ionomer unless they're using gold. Orly asked, is Emax restoration great for heavy bruxes? Well, I showed you 3 of them. And for me, my most important thing is I want to cement the restoration and have it stay there. And I will accept problems. I rarely see the problems. That's just still in my database. Emax is essentially bulletproof. And okay, if you want to do it all in gold, that's fine. All the other materials, zirconia is a great material, but the more aesthetic zirconias are not only a little bit stronger than is Emax itself. But the advantage of Emax is you can acid etch it and silane it. You can't do that with zirconia. And if you sandblast it, you might be creating problems, although we've never proved that. Certainly Marcus Blatz has a cement protocol, which is fine. But to me, on a heavy bruxer, I would use Emax. Victoria asks, thank you. CAD-CAM Emax, staining disappears in 2. How do you retain them in the mouth? If I'm not mistaken, we need to bake it in the furnace. I don't see that staining or coloring ever disappear, particularly if you do what I said. You just cut back little strips and add the fluorapatite on top of that. And if you use the new Zircad where color is built in, I don't think you'll ever see color coming out because the color is already built into the zirconia. So I don't think that that's really an issue. I certainly have not seen that. Ravel asks, how does cemented Emax compared with bonded Emax? Well, again, everything I do is bonded. I've never, since Dicor days, which is a long time ago, I've never done it any other way other than acid etching, tooth, dent and bond, or gluma, dent and bond, acid etch, silane, the ceramic, and cement from there. So cemented, everyone's getting confused with the word cemented. Cemented does not mean resin ionomer. That is a free radical polymer reaction, not dramatically different than a bonded. The difference between bonded is I can acid etch and kill bacteria. And I'm a Sokransky, so I want to kill bacteria, put gluma down to minimize sensitivity. Dan asks again, we need more MID, not crowns. I don't know what MID is. I do a lot of partial coverage, Dan. I don't see any reason not to. If I feel, the thing I'm most concerned is cracks and fractures. If I see a crack that goes through the tooth, that's going to be a full coverage restoration. As I said, I do a lot of partial coverage. But if I'm looking at a reconstruction, I'd rather do crowns. I can manage the case much better. I can open vertical dimension. I have time to develop and you see there's no difference between partial coverage and crowns. Look at the data. You have 17 years, and the next time I do it, we'll have 20 years. There's no difference between partial coverage and full coverage. Again, I don't know what MID means, but that's what I assume you're saying. What residence cement do you use for bonding Emacs? Well, I use the Ivoclar material, and only because I've used the Ivoclar material for years, I know how it does. What I do is I put it in, I acid etch, Luma, Dentin Bond. I have an assistant keeping everything dry. Often partial coverage I do under rubber dam, but I don't have to. Then I have the Emacs etched and I cement it down. I hit it with a light, 1, 2, 3. I take off the cement that's now soft, take alcohol and clean it into proximally clean. And then when everything's clean and clear, I hit it with a full cycle, and I use a good quality calibrated light. What do you think Raffaella asked, what do you think using porcelain over chrome cobalt to reduce costs? I don't think that's a good idea at all. I think that's a very poor idea. Porcelain fused to gold. Porcelain is all about the coefficient of thermal expansion. The chrome cobalt is never controlled. I would never do that. Never do that. How do you choose zirconia versus lithium disilicate? Again, it's a great question. I use zirconia when I'm in complex problems or have to splint. And the Zircad is a great zirconia. Lithium disilicate I do for almost everything else. It is my go. It's essentially bulletproof. And I can acid etch, and they don't come out of the mouth. And as you see, they also don't break. Michael asked, oh, I love these questions. Thank you very much. If Emacs can withstand so much pressure and destruction, can you comment on the possible reasons patients come to me from the neighbor dentist have so many broken Emacs? It may not be Emacs, because me and all my friends, certainly the data, I have never seen many broken Emacs. You know, people claim they have restorations in the mouth and it's of a material, and it turns out it may not be. By the way, there's other lithium disilicates where the database is not what the Emacs database is. One of those had to be taken off the market for a while. So, you know, it's a complex story. What you've experienced, Michael, I have not seen. I'm sorry. Marianne is asking, what type of finishing line and margin do you recommend for metal ceramics? I use a chamfer, and I finish with a koi spear burr to make sure I don't have any lips. What is the difference between porcelain butt and the disappearing margin? I have a very small millimeter butt, depending on what was there before. And again, I start with a chamfer, and then I use the koi spear, often with slow speed, and I just go through, set up the line angles, certainly improves parallelism, and then go from there. Do you see a place for gold restorations in prosthodontics? Absolutely, but not much. Not much at all. Michael asks, I was attributing the breakage to not having 1.5 thick, but it sounds like you don't believe this. I do not believe that at all. And the data, Michael, shows it very clearly. You can come well under 1 millimeter. You can come on 0.5 of a millimeter. Not that that's what you want, particularly in an occlusal third, but you can be under that. And I have no fears. My database shows it. My goal in preparation is 1 to 1.5 millimeter. But as you see, I measure each restoration by 7 points. And I report that in my database. I report that from the point of view of looking at the statistics and averaging. And I generally average about 1.2 millimeters in my preparation. But I don't believe this issue 1.5 that is has been described fake news. How does Emacs compare to porcelain fused to gold on second, or full gold crowns and second molars? It's really up to you. I don't have any problem doing gold at all. But from the point of view of what patients want, the fact that I can etch it and put it in, and even in reduced thickness, I don't have any problems with that. My wife asks, slides are not moving again. Sorry, I don't know what happened there. Minimally invasive dentistry, thank you. I think I've answered that question well. And then again, minimally invasive dentistry. And I believe in that. So that's not a question, but I don't believe it from the point of view of religion. I don't believe that you take situations. You see, I do lots of partial coverage. I think a vast majority of my work is in partial coverage, except when it gets into complicated issues with problems with decay, cracked teeth. Then I want a complete coverage restoration. Is a partial coverage, AMF asks, is a partial coverage restoration better for fractured teeth than a full coverage? No, I do not believe that's true. With a fractured tooth, I do not want to keep anything. I want to circumferentially grab that tooth in its entirety and hold it all together. AMF, that's a great question. Dan, it's all right. EMX failed from operator error private. I don't know why you say that. First of all, I've documented the failures. I've shown the failures. I've shown the concept of the teeth that are there. I see very little EMX. When there's a problem, I'll take the blame for it. I take blame for everything from the point of view of my work. And I think that's important. We all do. But I don't see that it's error initially. So Dan, thank you for that question. I hope I've cleared that up. And I don't see any other questions. Oh, no, wait. Operator error. So are there any other questions? I think my timing has been just about perfect for you. And I want to thank Viva Learning for allowing me the opportunity to share some of my ideas with you. Thank you.